Welcome you all. Today we are going to discuss hypertension and its treatment. Okay. So what is BP? BP is greater than or equal to 140 by 90. We consider as an hypertension. Okay. So the drugs we will use in hypertension will be normally diuretics will use, and sympathoplegic means sympatholytic drugs will use, vasodilators will use, and renin, angiotensin, aldosterone system inhibitor drugs. Okay. So normally we will call as ABCD drugs, AC inhibitors. Mostly ABCD drugs means AC inhibitors, beta blockers, calcium channel blockers, diuretics for practice only. So for theory purpose, we will remember these drugs as diuretics, sympathoplegic drugs. In this we will have beta blockers, vasodilator drugs. That means CCP drugs will come, potassium channel blockers and nitrates. All this will come. RAS means renin system, ACE, RBS. All this cover in this RAS systems. Okay. So we'll discuss each one. First, diuretics. Diuretics first drug of choice will be thiazide diuretics. Okay. So these drugs will decrease peripheral resistance. So how do you decrease peripheral resistance? By decreasing sodium level. Okay. So what are the diuretic of choice? Best drug in diabetic patient is indapamide. In gout patient will use indacrinon. Okay. So these are the MCQs mostly repeated in diuretics. Most preferred drug in diabetic is indapamide. First drug of choice is thiazide diuretic in antihypertensive as antihypertensive agent. Then in gout patient will use indacrinon. Next group of drug is sympathoplegic, that is sympatholytics. By inhibiting sympathetic system also we will control BP. So by inhibiting central sympathetic outflow, what are the drugs we will have in this one group is clonidine, that is alpha 2 agonist, alpha methyl dopa, moxonidine. So mostly in this group we will use alpha methyl dopa in pregnancy hypertension. So these drugs main side effect is sodium and water retention, that means edema. So when you are prescribing this drug, we have to combine with diuretics to overcome this effect. Okay. There are some other sympatholytic drugs, that is ganglionic blockers and adenosine neuron blockers also used to control BP. In these ganglionic blockers, we will have hexamethonium and trimethophan. In adenosine blockers, we will have reserpine, guanethidine, bretylium. Among these three, bretylium is cardiac defibrillator drug. This is most commonly used in arrhythmias also. So these drug main side effect is hypotension, postural hypotension. Okay, that means there will be BP fluctuation will be there when patient is changing his position from supine to standing position. BP fluctuation will be there. Okay, so in this group, main important drugs will be these. These are using most commonly in antihypertensive agents. What are those? Adrenergic receptor antagonists, that is alpha blockers and beta blockers. Okay. So alpha blockers main drug is phenexybenzamine. It is drug of choice for pheochromocytoma induced hypertension. Okay. This is most common repeated MCQ. Pheochromocytoma drug of choice antihypertension is phenexybenzamine and phentolamine, tolozoline. These are used in clonidine withdrawal and cheese reaction also. Next, prazosin, terazosin, doxazosin. These are alpha 1 inhibitors will use in benign prostatic hyperplasia patients. Then beta blockers also will use. Beta blockers mainly means selective beta blockers. If we are inhibiting beta 1 means beta 1 will have two activity. One is renin inhibiting activity. The next one is increased cardiac activity. Okay. So in this one, what are the drugs will have? Labetalol, carvedilol. Okay, these two drugs will have both beneficiary effects. Okay, that means alpha and beta both combination effect will be there. Carvedilol and labetalol. In this carvedilol will have one more beneficial effect, that is antioxidant property. This is repeated MCQ. Okay, recently 2K20 also they asked which of the beta blocker will have antioxidant property, that is carvedilol. It will have alpha and beta blocking activity also. Okay, in this we need to remember pheochromocytoma drug of choice phenexybenzamine, and in beta blockers which are having both alpha and beta blocking activity, that is labetalol and carvedilol. Antioxidant property drug is carvedilol. Okay, so you have to remember these things. Next, vasodilators. In vasodilators, we will have potassium channel openers and nitrous oxides. Okay. In potassium channel openers, these drugs will cause obviously dilation of arterioles. Examples of this one is hydralazine, minoxidil, diazoxide. Okay. Hydralazine, it will cause vasodilation by releasing nitrous oxide from the endothelium. Okay. So it is metabolized by acetylation. Okay. Fast, if you are giving fast accelerators, obviously we have to increase the dose. In slow accelerators, dose will get decreased. Main adverse effect of hydrolyzine is lupus erythematosus. Okay, this is emergency drug we will use in hypertensive crisis also, because this is major arterial dilator. Okay, so emergency situation also we will prescribe hydrolyzine. Next is minoxidil. This is also potassium channel opener. Mostly we will use in alopecia because it will enhance vasodilation, increase blood supply. So we will use in alopecia condition. Next, diazoxide. Diazoxide is a thiazide derivative. It will have major side effect, that is hyperglycemia and hyperuricemia. So we can't use in diabetes and gout patients. Next vasodilator is nitrous oxide. Drugs which are releasing nitrous oxide, obviously it will cause vasodilatory effect. So major adverse effect of nitrous oxide is cyanide toxicity and hypothyroidism. Hypothyroidism is due to thiocyanate accumulation. Okay. Next vasodilator drug is dopamine. Dopamine, selective dopamine is phenol dopa. This is also vasodilator. So we can use as an antihypertensive agent. Next is vasodilator group. What is the other drug is calcium channel blockers. These blockers will blocks L-type calcium channels. Okay, so they have three major groups. One is phenyl alkylamines. In this we will have verapamil. Then benzothiazines. In this we will have diltiazem. Then dihydropyridines. Most common drugs belongs to this group only. Dihydropyridines. In this group we will have nifedipine, nicardipine, nimodipine, amlodipine, all most currently using drugs all belongs to dihydropyridine group only. Okay, so this is very important group. So they will ask whether the group of the drug, or they will do options for which is excluded from dihydropyridine group. One thing is, next is what are the actions of calcium channel blockers. They will have vasodilator. Obviously they will have vasodilator drug. So vasodilating property, they decrease heart rate and AV conduction, and they and contractility also. Okay, so my first is vasodilation, so there will reduce BP, decrease heart rate, so burden will be decreased, AV conduction, so rate also controlled, and they will be followed by decreased contraction also. Okay, here the main drugs will be nicardipine, clividipine. Clividipine is a recently developed drug. This is nicardipine is old drug. It is main drug of choice for hypertensive emergencies. Now, clividipine is recently developed for FDA for hypertensive emergencies. Okay, if now they are asking any chances, clividipine belongs to which group? Okay, CCB. So obviously used for hypertensive emergency. It is also belongs to dihydropyridine group. Next, nimodipine is a drug of choice for subarachnoid hemorrhage. Subarachnoid hemorrhage drug of choice is most common. You have to remember. Okay. Next, verapamil, drug of choice for PSVT, paroxysmal supraventricular tachycardia. These three you have to remember. What is the drug of choice for hypertensive emergency? Drug of choice for subarachnoid hemorrhage. Drug of choice for PSVT. PSVT, verapamil. Arachnoid hemorrhage is nimodipine. For hypertensive emergency, nicardipine. Now they are approved clividipine also there. Okay. Main contraindication of calcium channel blockers is sick sinus syndrome. Means the heart rate is slow. So when those patients, if you are prescribing CCBs, patient will have bradyarrhythmias. Obviously, death of the patient will maybe happen. So we can avoid CCBs in sick sinus syndrome. Okay. Next, major adverse effects of CCBs is CCBs are vasodilator drugs. Major adverse effects will be reflex tachycardia. Why means these drugs will cause vasodilation. So there will be more increasing rate, so they have chance of reflexing tachycardia. Next is sodium and fluid retention. So we can combine with diuretics, they will flush out. Headache will be there because of vasodilation, headache will be there. Okay. Coming to next group. Next group is RAS system. Okay. This is major group in controlling hypertension. Okay. What is RAS means? Renin, angiotensin, aldosterone system. Okay. First of all, we will see. This may ask as a picture-based question also. They can ask whether which enzyme is this one, which drugs are blocking which enzymes related. They can ask. Okay, if you see this figure, normally angiotensinogen is a protein. It is produced from the liver. In this angiotensin will converted to angiotensin 1 with the help of renin. Okay, this renin will be blocked by renin inhibitors. Those are aliskiren and remikirin. Next is this angiotensin 1 is converted to angiotensin 2 with enzyme angiotensin converting enzyme. Okay, this enzyme will be blocked by angiotensin converting enzyme inhibitors. What are those? Captopril, lisinopril. These drugs will cause dry cough and angioedema. Why dry cough means? Because of accumulation of bradykinin in the liver, lungs. Okay, accumulation of bradykinin in the lungs will have chance of developing dry cough, and angioedema also they have chance in developing of angioedema also. Okay, next, once this angiotensin 1 to angiotensin 2, this angiotensin 2 will act on two receptors, that is angiotensin 1 receptor, angiotensin 2 receptor, and at the same time it will produce aldosterone also. When it is acting on angiotensin 1 receptor, we will have chance of vasoconstriction. Okay, next, angiotensin 2 receptor mainly and angiotensin 1, okay, minorly and angiotensin 2. In angiotensin 2 will cause vasodilation, that is minor effect only. When it produce aldosterone, aldosterone is an hormone, it will enhance the absorption of sodium, okay, sodium and water from the renal tubules, and potassium excretion. Okay, so thereby increase BP. So we can decrease BP by inhibiting aldosterone antagonist, and by inhibiting AT1 receptors by aldosterone receptor blocker. Okay, these are ARBs, angiotensin receptor blockers and aldosterone antagonist. So in angiotensin receptor blockers, what are the drugs we have? Losartan, telmisartan, valsartan. Among these, losartan will have additional beneficial factor, that is antiplatelet action also will be there. Okay. So in aldosterone we will have spironolactone and eplerenone. These drugs also mostly nowadays we are using ARBs as an antihypertensive, first line antihypertensive drugs. Okay. So in these groups, AC inhibitors will be beneficial in MI patient, diabetic patients, all those patients will be more beneficial with AC inhibitors. Okay. Next, potassium, these are aldosterone will be potassium sparing diuretics. So we should avoid with potassium sparing diuretics. Okay. When you are prescribing potassium sparing diuretics, we should avoid aldosterone antagonists. Why? Means they will enhance potassium, thereby enhancing chance of arrhythmias. Thank you.